Hello, everyone. I'm Wally Holloway, and this is Black Health Now. I am thrilled to have our panelists today talk about the topic of protecting Black mothers, a holistic perspective of the maternity crisis. We've talked about this before on Black Health Now from the perspective of newborns and new mothers, but today we're really going to drill down on the health of Black mothers, actually. And this happens to be Black Maternal Health Week, so it's very timely. So super excited to have our panelists. I'm going to introduce them now. This is a rich topic, and we're going to have a great discussion, and hopefully you all will learn quite a bit about the crisis that's happening. So I'm going to start with Dr. Richard Walker. Dr. Walker is the founder and CEO of Walker Healthcare Holdings, Inc., the Virtual Primary Care Connection, Inc., and a management service organization. He developed these companies as a response to circumstances of his mother and millions of other seniors, the chronically ill, and veterans when they were operationally abandoned by a non-compliant US healthcare model to meet their needs. He retired after 35 years of clinical practice with 20 years in OB/GYN and 15 years in functional and environmental medicine. He was a medical director of Concentra's Houston Medical Center Clinic, the busiest of Concentra's 300 plus clinics nationwide. He's also an author of many peer-reviewed articles and the book African American Healthy. Dr. Walker spent many years as a consultant in matters of quality and risk management, serving in this capacity on many hospital boards and departments. His new book, Black Health Matters, is giving the history of African American health, healthcare and wellness since slavery. It covers the reasons why Black Americans are still suffering from chronic illness, experience racial discrimination in healthcare, and what can be done about resolving these healthcare inequities. Dr. Walker also had his own talk radio program in New York City and Florida. Dr. Walker, welcome.
Thank you very much, and I'm honored to be here.
All right, so we also have Dr. LaTanya Hines. Dr. Hines is a board-certified obstetrician gynecologist, currently practicing at Kaiser Permanente's West Los Angeles Medical Center. In this role, she provides care to an array of high-risk multicultural obstetrical patients, in addition to her expertise as an associate clinical professor in the Department of Clinical Services for the new Kaiser Permanente Bernard J. Tyson School of Medicine. Dr. Hines also currently serves as the assistant physician in charge of the Baldwin Hills Crenshaw Medical Office Building in South Los Angeles, which happens to be the largest medical office building in the United States. Additionally, Dr. Hines has served as principal researcher with the National Institutes of Health on the side effects of oral contraceptives with new users. Her many lectures have included menopause, cervical cancer, healthcare disparities in African American women, and the effects of obesity and pregnancy on women in Southern California. Dr. Hines, welcome. It's nice to see you again. We're thrilled to have you here.
Thank you so much for having me. I look forward to our discussion.
We also have Dr. Michelle Ogunole. She is a health disparities researcher, social epidemiologist, and general internal medicine physician specializing in the care of women with chronic medical conditions. She has advanced training in quality improvement and patient safety science. She currently practices at Johns Hopkins Hospital in Baltimore, Maryland. Her research is focused on racial disparities in maternal health outcomes among African American women. She specializes in 4 main topics. Number 1, the role of general internist in optimizing chronic medical conditions in the preconception period. Number 2, postpartum chronic disease and long-term health outcomes related to complications of pregnancy. Number 4, African American women's experience with the healthcare system, specifically their experiences of racial discrimination and barriers to primary care follow-up after pregnancy. And she also focuses on creating equitable, community-driven quality improvement interventions around transitions of care from obstetrics to primary care for racial ethnic minorities who experience medically complicated pregnancies. Dr. O, as I'm going to refer to you as, welcome. We're thrilled to have you here.
Thank you so much. I'm so excited to be here.
And then we also have Dr. Denise Shervington. She has an intersectional career in public health and academic psychiatry. She is the president of the Institute of Women in Ethnic Studies, a community-based translational public health institute in New Orleans. She is also the chair of psychiatry at Charles R. Drew University. Dr. Shervington has held clinical professorships in the departments of psychiatry at Columbia and Tulane University, a graduate of NYU School of Medicine. She also received a master's of public health and population studies and family planning from Tulane University. She completed her residency in psychiatry at the University of California, San Francisco, and is certified by the American Board of Psychiatry and Neurology. A fellow of the American Psychiatry Association in 2018, she received the Award for Excellence in Service and Advocacy, prior to which she received the Jean Spurlock Minority Award. Dr. Shervington is also a member of the American College of Psychiatrists. Her recent publication is Healing is the Revolution, a guide to healing from historical, intergenerational, interpersonal, and community trauma. She also hosts the podcast Healing is the Revolution, in which her guests share and explore their healing journey through their traumas. Dr. Shervington, it's nice to have you here again. Thank you so much for joining us.
Let me unmute myself. Thank you. It's great to be with such an esteemed panel. Thank you.
Well, I'm thrilled that you're all here. This is a rich topic. You all have spent your lives dedicated to this topic. So, for the benefit of the people who are joining, we're all leaning in on this. And as we know, this has been, the statistics around Black women, and I'll just read one. American women, all right, all American women die in childbirth at a higher rate than any other developed country, while non-Hispanic Black women are 3 times more likely to have a maternal death than white women in the United States. And this is 2021. And as all of you know, this is not new. This has been going on for a while, but there have been some high profile cases in the last few years that's really raised awareness and attention to this. Serena Williams being one of the more prominent women who experienced complications during pregnancy. And now people are really starting to lean in and want to understand more. So I'm thrilled that we have a panel that really is multidisciplinary, because it's not just about what happens during the pregnancy journey itself in those 9 months, but it's also what happens pre-conception, as Dr. O knows, and certainly postpartum as well. So we're going to dive into it. So let's get started. So Dr. Hines, I'd love to start with you. So, the stats that I just talked about around maternal morbidity and mortality among Black women have been known, studied, and discussed for a while. And the awareness has increased. Do you think we've made any progress here? Are things getting better, or do we still have such a long way to go?
I'm going to come across, or at least say that I'm hopeful, and say that we certainly have made some progress. And what that means is that from the beginning, when the statistics were first started back in the 1800s, it was probably about 300 per 100,000 women that were dying with regard to African-American women. And those were the slaves back, basically, in comparison to the white women, who were still pretty high, but it was not, 3 or 4 times that amount. It was a much smaller issue. What we've learned over time is that it is a whole person issue. It is the vessel in which the baby grows. And more importantly, it is a systematic process that creates the individual that creates a baby that's full term. It is not your resources. It's not your education. It is not, we would hope, the love that's around you that should help. But do I think, in a nutshell, that things are better? The short answer is yes. Do I believe that we can absolutely get better? The answer is yes. Do I see where we go left or going in the wrong direction? Yes. And that is number one, do not blame the pregnant patient. It is not her fault that she has a preterm delivery. It is not her fault that she did the best she could with the weight that she started with the blood pressure she started with. She is doing her best. Our job as healthcare professionals is to mitigate those risks and to do the best we can to increase the outcomes that we all expect. Education and health literacy are important as well, but the overall issue, and I know that we're going to get to that today, is the social determinants of health. And ultimately, how does that affect our patients is the wealth and the wealth gap, and that is racism and how it has an impact on every single facet of our lives, including in the end, when you show up at labor and delivery for a baby.
Wow, that's a lot, right? And it's, it's astounding as you kind of talk about all the things that impact it, but, it's not the mother's fault when she shows up, but obviously, you work with women every day during that critical journey when they're expecting. But Dr. O, you've done a lot of work in the area of what happens prior to that. And Dr. Hines talked about some of the, the social determinants of health, which we're hearing more about lately too. It's not just, what's happening with the individual, but it's, their surroundings. And I know you've done a lot of work in this area. Can you comment on, what impacts it beyond just pregnancy, preconception? I know you've done a lot of work in this area.
Yeah, absolutely. And I echo everything Dr. Hines said. You know, I think one of the hard and challenging things about health disparities in the United States, when we look at this across a number of diseases, it's not just pregnancy and obstetric care that we see these disparities for Black women. And sometimes we say that you could pick a number of things and the root causes are actually very similar, if not almost exactly the same. And so the very same things that Dr. Hines talked about, and I think we will get into this, but these social determinants of health, the things that where people live, work, and play, all of those other things that impact their health, these are the things that end up mattering for disease. And I think when we think about preconception health and we think about chronic disease and we look at the numbers in terms of maternal morbidity and mortality, which just means not just the fact that women are dying, but the people who might have complications that impact their life, we have to think about those people as well. And so when we see that, we know that over time, the number of women who have chronic disease entering pregnancy has dramatically increased in the United States. These things like obesity, chronic hypertension, diabetes, a lot of them run together. They've increased over time in this country, and those things increase the risk of pregnancy complications. And so, and then the other side of it is that sometimes pregnancies aren't planned. And when we think about the reproductive age women that are having babies, not everybody is seeing primary care. Not everybody knows that they have chronic conditions that really need to be managed, that can really, you know, we try to optimize them before pregnancy as much as possible. And so I think it's all of that. And that also is potentially an access to care issue. It's potentially, you know, an issue of whether or not people feel safe within this healthcare system and whether they want to seek care, whether or not they have physicians that look like them, that can maybe answer their questions to alleviate some of those concerns. So I think it's a lot of things that lead up to that moment of pregnancy. And, you know, as an internist, and the way that I explain it to women is that pregnancy is a stress test. Mm-hmm. Your body is going to go through a lot. And so we think about how do we prepare women for that stress test and optimize them for that stress test so that they can do well. And so I think that there are so many things that increase the risk going into pregnancy and that we can potentially work on. And the last thing I'll say is that it is one of those things that if we fix the big picture structural issues, I think it'll have this domino effect where it will improve the chronic diseases that we see and the disparities we see in that, and also improve the pregnancy complications, which would also improve the long-term chronic disease that happen as a result of those. And so I think one thing is to think about this as a life course issue, right? And we have to continue to work on these problems to reduce these disparities.
Okay. Dr. Walker, I want to get you in here because I know you've done a lot of work on the environmental aspects, which in my mind ties in very, very closely with the social determinants of health. Can you comment on your perspective regarding some of the impact of the environment as well?
Yes, and again, I want to thank you for having me on this panel with these distinguished colleagues. And, you know, pretty much we're all saying the same thing. We understand what the underlying foundational root causes of so many of these things. And it's the American healthcare system. Actually, it's not a system, it's a model, and it's a flawed model. And yes, we've made a lot of progress in and using this flawed model, but there's one component in the Black community that we you almost never hear spoken about. We know about some of the issues in the industry, the healthcare industry, but just as I focus attention on in my upcoming book, Black Health Matters, one of the things I try to emphasize is the impact that the environment has on our lives, short term and long term. And I often ask colleagues, I ask family, I ask friends, when was the last time we had a discussion about the environment and how the environment is affecting us? And we generally don't, as a people. We do not discuss the environment. And when you do mention something about the environment, most people think that as you are discussing about the things about the environment, we're talking about environmentalists, the conservation of plant and animal life. That's not what we're speaking about. We're talking about the systematic implementation of industry in communities of color, where they took advantage of those communities, short-term and long-term, where they, a lot of the industries put plants because they had cheap labor, and they also knew that that cheap labor, if there was an environmental issue from that manufacturing plant, that those people in the surrounding communities did not have a political voice or a legal voice in order to oppose or make their voices heard. Now, from the standpoint of what we're discussing today, one of the things that's so important and so aggravating to me is the fact that as we look at the various events that happened, let's say Mr. Floyd, we naturally and purposefully verbalize our position against those infractions on the lives of individual Black men and women. At the same time, there's almost no word about the thousands of unborn children because of the problem of the environment. And I say thousands conservatively, it is probably tens of thousands. And as Dr. Hines started out, she said, if you were to look at the educational component, that doesn't measure up to correcting the inadequacies and the problems that you find in African-American women and in their pregnancies and in the children. It also is not reflected in the fact that when underserved women receive prenatal care, that also doesn't change the outcomes. So we got to start asking some questions. What's going on? What is it that we're missing? And one of the things that a lot of people are unaware of, both in the medical and the general and industrial community, is that as we talk about Black women, so many of our Black women are overweight or obese. Now, what does it have to do with the environment? Fat cells are the repository for toxins. And so when someone becomes pregnant, you have an environment where that pregnancy is attempting to thrive, but it comes into its existence in a toxic environment that remains toxic for the rest of their lives. And to what degree, and there's all kinds of articles that talk about the air pollution, talk about particulate matter and how it affects women, and it affects the pregnancy outcome, but it's something that we don't talk about. And this is one of the reasons why I'm so thrilled to be here, to finally shout out, I call this a mountaintop, and say, this is a conversation we've got to have. We have to start talking about what is being done to the communities. The Environmental Protection Agency has stated emphatically and definitively in print that the communities of color are the most toxic communities in America. What happened after that? Nothing.
Wow, I've never quite heard it put that way. The most toxic community ever. That's pretty telling. So, we've kind of talked about the chronic illness and conditions where people live, work, and play, the environment. Dr. Walker, you talked about the toxins, but there's another element to the stressor. And I love Dr. O said that pregnancy is a stress test. So speaking of stress, Dr. Shervington, I want to get her in here. She's a psychiatrist. So she works with communities of color every single day to help overcome trauma associated with, life stressors. And we know for the Black American community, there are many. So Dr. Shervington, I'd love to get your perspective on this conversation around the stressors and how that impacts potentially the health or illness associated with pregnancy in Black women.
Thank you. And let me just thank Dr. Walker for talking about the environment, because across the state in Louisiana, we have some of the most toxic spaces in the country. So thank you. And to my other panelists who really presented the whole woman and not just her during pregnancy, thank you for having such a broad picture. We have unfortunately artificially disconnected the mind from the body. In fact, the mind is the only aspect of the body that we know. We don't know our kidneys, we don't know, well, maybe some of us know some of our GI system, but we have artificially disconnected the mind from the biology of the rest of the body. So when I'm talking about mental health, I'm talking about the whole body of health. So again, thanks to my panelists for being so clear about that. When we talk of the body has its innate capacity to adapt to changes. In fact, some of these stress hormones that we hear increasingly about, they acutely are there to help us figure out how we survive. And how do we create stability through change and when there is stress? However, if the stress is continuous and the environment is toxic, physically toxic, and also lack the kinds of supports that are needed to buffer some of that toxicity, then the body is going to be chronically stressed. Those hormones that I think now have become part of the vernacular, cortisol, adrenaline, they are going to damage the body. And they're going to keep the body in a state of wanting to survive. We cannot maintain that high level of being in the survival mode because it shunts the energy from we are making choices when we're surviving. We need the muscles to be able to run or to fight. We need our brain a little sharper. But some of the other organs, we steal the energy from them. And so that sets us up for a lot of physical illnesses and also for mental illness. And so I want to talk about mental health as part of physical health, because the only way we know ourselves is through living in our body that operates through the biology that we all know.
I love that. I think that's important, as you say. Do you think that, there's a way specifically, with Black women that we can help them kind of better navigate a world where these life stressors are coming at us from every direction? Like, how can we help them? Because as Dr. O specializes in, it happens pre-pregnancy, and, these are effects that have to be dealt with during pregnancy and after. So how do we help Black women better navigate so that they are mentally and, to your point, physically healthy as a result?
I think we have to recognize that there are multiple levels at which the stresses come for us, at all levels of our existence. And to also remember that in a society that's based on white supremacy, we were not perceived, we were robbed of the construct of our wholeness. We were said to be less than, like we're not beings, we were 3/5 human. So to me, mental well-being is taking back who we are, our whole selves, our full selves. That requires work. It requires being able sometimes to create the space to be still and reflective. At the same time, we have to be fighting all the systems that are coming at us. So I think we have to recognize that the forces that come of us, they're strong, they're persistent, and we have to enhance our own resilience and capacity internally. And this to me is some of the benefits of any process of self-reflection, whether it's meditation, mindfulness meditation, or seeing a therapist, or being in nature, or being the creators of all those things that bring us joy, that we take delight in our existence. We are going to have to take the time to know ourselves and become accountable enough to ourselves that we know what we need to do to stay strong.
Can I add a couple of comments? I thought that was just so beautiful.
Of course. Please, Dr. O, yes.
Yeah, I love this idea, and I think it's so true that our joy and rest and peace, all of that is a form of resistance that I love how Dr. Shervington put it, so that we can reclaim our whole selves. And I guess the only, the two caveats that I would add, I always try to make sure when I talk about these issues to be really clear that when we talk about the systems of oppression, the white supremacy, the racism that we encounter, that is not the job of Black women to fix that, because that's not a problem that we created. But I also understand that we live in this world, and as we call for structural change to address some of those issues, people still need solutions. And so that's why I love what Dr. Shervington said. I think the other piece of that, at least in terms of reclaiming our wholeness, is tapping into what is so beautiful and I think strong and about our community, which is that we find restoration within our communities. I think that's very powerful. And sometimes I talk about one organization all the time. People probably think I work for them, but I don't. But I talk about like the Girl Trek movement, which is an organization founded by Black women, and the goal is to reduce cardiovascular disease in Black women, which is the leading cause of death for Black women and a leading cause of pregnancy related deaths as well. And really the idea behind that movement, and this is just one example though, is that when we walk as a people, historically, things change, and you can walk together and it's something free that you can do, and you can walk with your sisters, right? And start to think about what it looks like to walk in the direction of your healthiest life. And I think that there's something really beautiful about claiming that. And they also have a mantra that in general, when you find the way forward, when you start to learn, I think that's what we're doing here. You go back and you get your sisters, you go back and you tell them what you've learned. Mm-hmm. And I think that's something that we have been doing in our communities, and we have to tap into that at the same time. So I just wanted to lift that up, that there are things I think that we can do. Obviously we're in a pandemic and there's ways that we do that. Right. We've had to find new ways to figure out how to stay connected, but I think it's been something that has kept us in hard times. And it'll continue to keep us as we are, living in these moments and trying to do the best we can in a system that wasn't made to serve us.
There you go.
No, I love that. And it's like, strength from our communities and really looking to our communities for that. That could help in a very practical way too. Dr. O, you talked about walking, right? I mean, we just talked about where people live and where they play, and, that also impacts their health, can impact change in a positive way. So that could be one of the big starts too. So, but just kind of going back to how are Black women like leaning in to try to alleviate some of the stress and try to find peace with it. One of the things that I've noticed, and I'd love for Dr. Hines and Dr. Walker to comment on this or others, that, I'm reading more that Black women are really seeking out alternative centers and care providers for their pregnancy journeys and their births, like birthing centers and at-home births, because for all the reasons that you just talked about, they don't necessarily feel safe in the healthcare system when it comes to the most important thing that a woman can do, which is give birth. So they're looking for other places to do that and other care providers to help with that. Do you see that as being something that's increasing, and I'd love your perspective on it, to know if that's something that's going to increase, and is that a good thing or maybe not?
Pick me.
Yeah, Dr.
I
Hyde,
would,
please.
I would like to say that many of my, over this, this will be my 20th year practicing medicine since residency. And as much as I've seen happen in the past 20 years, I've seen us go backward and forward. And, we said this drug worked, and then all of a sudden we say, no, we're not using that now. It's the blue pill, it's the red pill, it's whatever. I'm going to say that holistic ways of thinking about the whole person, acupuncture, acupressure, meditation, clean eating, exercise, spirituality, the list could go on and on. What I am saying is that from a Western medicine, evidence-based, data-driven system, is that those ways of addressing the same issues are complementary. This is Dr. Hines speaking, as opposed to replacements. And why do I say that? Because as Dr. Shervington brought up, the mind is powerful. And when the mind believes, so does a man thinketh, so is he. So if you believe that you are creating a child in an environment where you feel loved, where you are feeling cared for, where you believe that the people are in your corner advocating for you, there is no question that that serves a much better and richer environment than the opposite. What can Western medicine do? Point out when it doesn't appear the pregnancy is going as well as we would like, and the combination of what we call the birth outcome, which for most physicians is what we look for. Is she alive? Is the baby alive? Did they deliver on time? Is that a good outcome? Birth experience is what is lately being talked about. And I am not saying that birth experience is any less important than birth outcome. But what I see is that the birth experience of delivering in a bathtub, delivering in the woods, delivering with no one to support you, and expecting the same outcome is the question. Over 100 years ago, or even less than 50 years ago, women died in childbirth commonly. And we said, that was a bad thing. And of course, disproportionately, it happened to Black and brown people. Now we don't accept that as a norm, despite the fact that there is a higher incidence, because we believe that we can intervene and make things happen. So I am of the mind that there is complementary systems that can work together to make women who, it's only been, 100 years, 256 as slaves. 100 years later, we were civil rights, and now we've got 40 years later, first Black president, and now we're continuing to hang and kill people. We're still working on this. So I would say that there is a complementary system as opposed to replacement.
Okay, thank you, Dr. Hines. Dr. Walker, do you have a perspective on this?
Yeah, I've got so much going through my mind right now. I'm just wondering, are we going to continue for another 5-10 hours or something like that so we can get it all in? When I was practicing obstetrics and gynecology, I began to recognize the inadequacies of women giving birth in the hospital. I started the first licensed out-of-hospital birthing center in the state of Texas. The license number was 0001. Later on in my career, I began to get disillusioned with the traditional practice of medicine. So I subsequently changed to functional and environmental medicine, which I felt gave me a lot more depth and a lot more variety of what I could offer patients. Having said that, one of the things I find is that it's frustrating when we look at the environment that we're in as healthcare professionals, and then we wonder what can be done when and if you ask the question, what can be done within that context, it's all about waiting. They pass on the effort that things in society have to change before we make the changes internally within the practice of medicine. And when I think about this, I really get angry because we waited from slavery to become free. We waited from being free in order to become a citizen. We waited to get the right to vote. We waited for the civil rights movement to make changes in society so that even though I have the right to vote, you don't want me to vote and you're going to do everything, i.e. the Ku Klux Klan, et cetera, to keep me from voting. And it's about waiting. And so in my book, Black Health Matters, it's time for us, and I think this dovetails with what's being said by the rest of the panel, it's time for us not to wait anymore. It's about empowerment. It's about doing what you know to do and learning more about the things that you may not know what to do, about how to take control of your destiny, your healthcare destiny, your life, your thinking, everything that we're all about. You know, it's absolutely amazing when you look at the history of African Americans or Africans in America, the resilience that we've had over the course of these years on anything that we do comes out to be marvelous. With all the opposition, with all the resistance, with all the things that we are confronted with, how they have attempted to stop us from at every turn, and yet we still prevail and overcome and excel. And so when I look at that history and see how marvelous it is, I try to condense it down into empowerment. We can't wait any longer for the healthcare model to change for us. We have to do something. We have to do whatever we know to do to make a difference. And everyone on this panel has spoken about ways in which to do that.
Yeah, I think that's powerful and that's great and that's important. And I love that it's because the issues that we've talked about, you know, Dr. O said it's not for Black women to fix the system, like, right? We didn't create that. But the things that we've talked about are the system, it's the providers, it's the individual, it's the environment. Those are big issues. And then you have the patient sitting in front of you all, right? And you go, wow, and she's sick and she may be expecting or she wants to conceive, and there's a lot of stuff, there's a lot of decks kind of stacked against her. So Dr. Walker, you talk about resiliency and how everything ultimately comes to our community ends up being marvelous. I love that you said that. So what do we do? Like, how do we, this concept of empowerment, I love it. And we are certainly capable of empowering ourselves to impact our lives and change the best way possible. But I'd love to really give the folks who are watching like some really tangible things that we can do, because when you listen to the stats and you listen to all the kind of the barriers that exist, it feels like, Dr. Shervington, your patients must think, oh my God, this is insurmountable. How can I overcome any of this?
I think that to find our power, we have to know ourselves. And we are not taking enough time in quietude and solitude to really understand who we are in relationship to the world around us. We're oftentimes, we're keeping it moving, we're running from here to there. And I know that some of the structural factors keep us that way, but at some point we have to liberate ourselves. We have to think about, what does being free mean for us? Who are we? How do we care for ourselves? And we can only care for ourselves if we know ourselves. We have to know the sensations in our body. We need to understand the thoughts that we are creating. And that is power. That gives us the agency to know how we can manage and be accountable to ourselves for our existence.
I love that. So then, that's, I think, it says a lot, right? Really, what are the structural factors, but there's so much that we can do to liberate ourselves once we're in touch with ourselves and we have the relationship and really understanding ourselves in relationship to the world and knowing and understanding that. I think that's amazing. So, Dr. Hines and Dr. O and Dr. Walker, like, what do you say when the woman is sitting in front of you and she's saying, wow, and you're diagnosing with a chronic condition, or, she's got a complicated pregnancy and you're worried about her. Like, what kinds of things should Black women, when we show up and interact with the healthcare system in the context of this topic today, which is, women who are expecting or they want to expect, Dr. O, if they're planning for pregnancy, what do you tell them? How do they navigate it?
Yeah, I think a couple things, because I think words matter. So, one of the things that I try to stay away from is saying that, because you're Black, you're more likely to have X, Y, and Z. And I try to say that, there are a lot of structural issues that have happened in this country. And because of that, that has historically and present day put Black people at risk for X, Y, and Z. And so these are the things that I think that we can work on together to make sure that you have the healthiest outcome possible. And the one thing I'll say from a really practical standpoint as a primary care provider, because I think part of it is, one, we have to meet people a little bit where they are and understand some of the social determinants of health that may make it challenging to do some of the things that we're requesting. And then the other thing is, we need to celebrate the wins, however big, small they are, because I think it's important to tell people, I know that you're trying, and every bit helps. And so the other message I'll just say in general is that I think sometimes people, when we talk about chronic disease, when we talk about health, like when we talk about weight or lifestyle, it feels so big and it feels unmovable. And I try to say, let's just chip away at it a little bit at a time. So I always say, like, I had a patient who was drinking 17 sodas a day. I just said, can we go to 16? That's it, And people think that's crazy, but that felt movable for them. It felt doable. And of course, over time, we were able to get to a better place, right? Where it was really meaningful for their health. But it was different for me saying, you got to stop drinking soda. You need to stop eating out. You need to stop doing all these things. And they leave with this list and it doesn't feel possible. The same thing with, exercise. And when I was talking about walking, people think, oh my gosh, now I'm gonna have to exercise for an hour vigorously and out of breath. I don't have time. All these other things are going on. And I say, it would be great if you can get out and do as much activity as you can. But if you do something, it's helpful for you, for your health. It matters, And so I think that's kind of my general approach when I think about these topics, and trying to be realistic and meeting people where they are, and making sure I understand what are the things that might be keeping them from getting to what I call their healthiest life. That's our goal. Yeah. Like, I want Black women. I love what Dr. Sherrington said and Dr. Hines said, Dr. Rocker said everything, but I want Black women to be free. I want them to live their healthiest and most fulfilled lives. And what does that look like? And how do I help them, not empower them because they have the power themselves, but I'm just there to help them recognize the power that they have and make sure that our decisions that we're coming to together are in line with that. And in terms of pregnancy, I think the beautiful thing is a lot, we almost always have the same goal, right? Like, we want a healthy mom and a healthy baby at the end of this. And so I think it's also a very special opportunity to really talk to women. I think they're really engaged, and also start to bring up the fact that this is a great time to also think about all the other issues this may have brought up about your health. And this is a great time to start thinking about that for if you have another baby, and even if you don't, just in terms of the rest of your life, how to start changing your mind. And I think that is really powerful and it's important.
I love that, chipping away at it a bit at a time and celebrating the wins and meeting them where they are. And most importantly, you said one of the things that's really powerful, you want Black women to be free and recognize their own power. I love that. So Dr. Hines, when you have your patient sitting in front of you, how do you coach them? How do you help them navigate their health journey during pregnancy?
I would give two examples. First of all, half of all the pregnancies in the United States for many years are unplanned. But there's a difference between unplanned and unwanted. And all the panelists know what I mean. So an unplanned, it is always there goes the gardener, happens every time. But the unplanned versus unwanted. And so we have to start that conversation with prenatal care by saying, how you got here is not as important as what we do going forward. And what I mean by that is that I am an agent for change and advocacy for them. I call their baby my baby. I know that sounds strange, but I'm like, how's our baby today? How are you doing? And it's my baby. So when we talk about their weight and what we are expecting, and when we can get them between a certain amount and they're doing the best they can, you celebrate all of that. And if they're a little bit above it, you say, you admit, and you say, look, I know I'm a bit intense, but I want what's best for us. It's my baby too. So here's my plan. I am going to not go above this level as best I can, hoping and expecting that next 4 weeks from now, that's where they expect to be. And they will do it. This is a time in their lives when they want so much to be able to create another human being that they can love and cherish, who perhaps may not have the same kind of trauma that they've experienced. They are very motivated to change. And so I feel very empowered to be able to be that advocate and say, these are the things that we want. And when things aren't going well, that's okay. I'm still here. You can still email or call me. We can still work together. So I think that kind of strong advocacy, being able to put yourself in the shoes of your patient and let them know that you are the person or one of many that can really help them in this journey, and to let them know that we are going to do well together, that somebody really cares. That's the listening and really hearing. Wherever you might work, if you've got deep pockets, Kaiser Permanente, then you got resources, right, to help with housing to some extent, to help with finances, and to make sure that their living situation is as secure as you could make it. So we try to put our money where our mouth is with regard to Kaiser being the answer for healthcare in the United States. I'm drinking the stuff and believing that it's true and trying to make it happen for our patients. And of course, I strongly believe in the mind-body connection like Dr. Shervington. I can't say it as well as she did, but that finding your power is knowing that you have it within you and that no one can take that from you.
Thank you. Dr. Walker.
Yeah, one of the things I used to like to do and still do when I have the occasion to do it is find the power of agreement. And what point or what thing can we agree on that we can live with together? And notice I'm echoing what Dr. Hines said. It's not about what you can do alone, but what we can do together. You as a patient, me as a provider, okay, we're a team. And we've got where's that power of agreement, which is extremely potent in terms of changing behavior, changing attitudes. I also used to do this little thing, we don't have prescription pads anymore, but I used to write a prescription when we came to a power of agreement. I would ask the patient, I would say, okay, how's this going to go over in the house? It's one thing to say it here in the office, but how's this going to go over in the house? I mean, is this going to be something that's accepted? And, there are two different worlds. There's that professional world where you're going to see the doc and then you go home. And so I would ask them, if I were to write a prescription about what we are agreeing to, and you keep that in your purse, and when the issue comes up at home, you can say, I have a prescription, regardless of what it was. I would write it on a prescription and say, here's your prescription. Okay. So if that situation arises about what you are challenged with, take out your prescription and let that prescription help you get to where you would like to be to overcome some of the circumstances. Now, take note, I'm not just talking about what's happening in the health community, but I'm talking about what happens in life, because that's what we have to deal with. Dr. Sherrington says it so wonderfully, but it's getting that mental attitude where we have to recognize that I have permission to make a decision about what benefits me. And a lot of people are looking for permission to do the thing that they think is important for their own life. And a lot of times they don't get it. So what I try to do is give them the permission to execute what it is that they wanted to do.
So you all are amazing physicians, and the patients that you work with are like it's great that they have you as doctors and taking care of them. But, we also touched on, a couple of you touched on kind of like this healthcare system, when they don't have physicians like you all who are going above and beyond to help them through a journey, how do they advocate for themselves? There's a lot of stuff out there. They may not have a physician that listens or, hears their concerns or is partnering and, making agreements and considers their baby, her baby or his baby. So how do we help them navigate it if they don't have physicians like you? I see Dr. O, did you want to jump in first? I see your hand up. Or was that by mistake?
I think I accidentally did that, but I'm happy to talk. I'm happy to talk about it. I do think it can be challenging. I mean, I'll say a couple of things, and I recognize that this is not everybody's. Not everybody has this privilege to be able to change providers when they don't feel comfortable, right?
Yeah.
But if they can, I always encourage people to, if they have that option, that they should go with their gut. And should try to find somebody that they feel like they can actually talk to. I think I hear a lot that people will leave encounters with their providers or their, and that they won't really understand what happened. And I've done a lot of translating for people because they didn't feel comfortable asking questions, and so I think that even some people feel like it's just like I was being really mistreated, but I always tell people, like, if you can't even ask the questions that are important to you because you don't feel comfortable, I think that's something to really think about too. But I recognize not everybody has that the privilege to be able to move providers when they want to. And so, some of my research, and this is around pregnancy, has been around the doula workforce and kind of this idea of having support during pregnancy if you can. And I think there still are a lot of structural challenges to make sure that people know what a doula is, what they have access to, or how they can access a doula, and making sure it's affordable, especially for Black women. And, this week, our vice president held a roundtable for Black Maternal Health Week. And she actually had some doulas on there. And I thought one of them said something that was so powerful that people have this idea about doulas of somebody like sitting you on one of those bouncy balls and helping you, but really it's about creating support and advocacy. I think not just during pregnancy, that some of these doulas, and the ones that I work with are community-based doulas, which really means that they're out there in the communities, they are known to the communities that they serve, and they're doing the extra things that I think Black women in particular may need, which is trying to help navigate those social resources, which end up being so important. And then a lot of them, or some of them, I think, are trained with this idea of justice and anti-racism, and really centering the needs of the mother in front of them. And I think just setting intentions about their pregnancy, whether or not things don't always go as planned, but knowing that you have someone by your side. And we know from data and research that it's different than just having a partner, even though partners can be really, really helpful and meaningful in the delivery. It's different. As I think about people who are in their first pregnancy, they don't even know what to expect. And I think it's hard if you don't have somebody who can at least talk you through that. And a doula means a helper of women. And I've always thought that was very powerful, because I'm obviously very into sisterhood and that idea of really being there for somebody and having someone focus on you. And so I always just try to lift those ideas up, because I still think that not everybody knows that those are potential options for them. So I'm just lifting up that as one, potential strategy for people who may not be able to switch providers. And even if they love their provider, I think it's great to have an extra support person. And I know COVID and the pandemic makes this very, very challenging. That's been one of the challenges that I know we've been working from an advocacy standpoint about whether doulas can be in delivery rooms currently. But I just wanted to lift that issue as one potential option.
Thank you. Dr. Walker, Dr. Hines, or Dr. Shervington. Again, my question was, if they don't have providers like you, is there something that you would recommend that they do to advocate for themselves and make sure that they're getting the best care that they can?
I think oftentimes, it really again starts with self. I've had patients different, but they're on medications, and I ask, what are you taking? I don't know. Well, we should know. And, I think if we have a culture that's affirming that the self is important, and we have to do that. And I keep saying that because I think this is what I'm seeing in us as Black women. It's so easy to live on the surface of our lives. We have to get in, because we're scared of the pain. We're scared to get to know ourselves. And as the psychiatrist here, I will say that's the liberating thing. And then all these other things become easy. So when I know myself and I care for myself and I love myself in a meaningful way, I'm not talking about narcissism, but I think I have something to contribute to the world and to myself, then I will do these things. I will find a doctor who is the right fit. Sometimes it's not the first person. I will be interested in my condition enough to get the information. I will seek out the doula. I'll seek out the Black doctor. I just want to say we do better with Black physicians. I'm sorry. Because, Wally, you said not everyone is having this. And if as a Black physician, we are not caring for patients like these amazing doctors have said, then we need to examine ourselves and do some work. But I think we're better with each other.
Yeah.
And with the complements, the doulas, the midwives, we're better with ourselves.
Yes, yes. We've had panels before that have talked about that very thing, but I think Dr. Hines, the last panel you were on, we talked about it's like 5% of all physicians are Black physicians.
Yeah, only 2% are Black women. So, we're all unicorns on this panel here today. But I think that we need to accept that responsibility. Each one teach one. That painting that's right behind me, my favorite painting, showing how there is the help, right? Reaching up and reaching down. Mm-hmm. And we know that where we trained, where we practice, the physicians do not look like us. Mm-hmm. And I say, where and when you can and how you can, each one teach one. And that means by example, mm-hmm. and by deed. Mm-hmm. Let your colleagues know what you believe to be good care. Let your colleagues know when they say something or do something that is unacceptable, yet they thought it was okay. Mm-hmm. Yes, you being that person perhaps will get the slant eye, but you will do so much more for helping that next patient that they see, that they want to make those similar comments about, that they know that there is a colleague that knows that is unacceptable and that the standard of care should be met and exceeded at all times. So we are the change that we want to see. That is why I sit on the admissions board for the School of Medicine, trying to get as many students in there of color to be the next generation. That is why I'm always pushing for mentorship for our young students to make sure that they understand the beauty of the profession in which we practice, but also in my own family and in my friends, be the example of what you expect and want to see. And for those patients who are not with someone who they trust or feel comfortable with, here's where I'm a little radical. I say stand and plant your feet. Ask for the supervisor. You know, Karen, do your best Karen impression. There's somebody who's supervising everybody. We all answer to someone.
Mhm.
Even if you're in private practice, you answer to the insurance company that's paying for her to see you.
Mhm.
Stand and be counted. Stand up for the importance of what you are trying to receive. And yes, you're going to ruffle some feathers, but once again, that patient is setting an example for all the rest of the patients that didn't ask the question. So each one in our own way represents this little piece of radicalism in trying to change the system in a way that is beneficial to us, knowing it was never created with us in mind.
It's very true. Dr. Walker, I'll give you the last word on this question.
Thank you. It's for me, it's a difficult question because it has so many components to it about things that you would like to do that you hope you accomplish. So yeah, it pretty much for me was predicated on who the individual was that I'm dealing with. And so I didn't have any one single methodology, one formula. I think the most uniform thing that I did or would do was very similar to Dr. O, and what she did is ask the patient, who is your advocate? Do you have an advocate? If not, how can we find an advocate? Because that healthcare model is way too big for you to try and navigate alone.
Mhm.
And I was very quick to tell a patient the same thing, that if you're not happy with a particular provider, there are so many providers out there that you can try and find out about. And what I would do is I had a little methodology, and that was, depending upon the specialty or the issue that they were dealing with, is listen, you got a lot of friends, ask your friends. Ask your friends who are like you, whom are they happy with?
Mhm.
And then use that as the stepping stone of what you do. But also, it's about, do you have someone to support you who's at home, who's a friend, who's your mom, or or your husband, or someone else who can be your advocate, so that sometimes when you don't have the strength, which happens, and we all know that, you don't have the strength to confront the system, if you will, is there someone who can do it for you so that you don't feel overwhelmed to the point that you do nothing?
Mhm.
And so I try to find what works for you. And it's not about me, it's about us. If I can help you, that's great. I had someone on a radio program ask me yesterday, Dr. Walker, when you find a colleague who you are unhappy with about things that they are doing, what do I do personally? I said, I have no problems with going to them. It doesn't matter whether they're black or white, but we know we're talking truth here. The majority of the issues I had were with white colleagues. I have no problem telling you to your face what I don't like and what I will not allow you to do when I'm present.
Mhm.
Now, that's what I did on a personal note. And that may not relate to any patient or anything the patient in their world or their environment. It's something that I would do. But that resonates for the next person who's a person of color who may be having that challenge. And I can tell you, like what Dr. Hines said, I'm kind of rebellious. That's how I got where I am today. I'm rebellious coming out of the projects, the Johnson projects in New York City. You know, you gotta be a fighter in order to find your way to get where you want to go. And if you're in the way and I'm going in that direction, please don't try to stop me. So, you know, I've got that rebellious nature, and you can probably tell from, you know, my countenance, but that's the way it is. And a lot of times the world doesn't like it, but they didn't like you before the fact. So what's up?
Thank you so much. We're actually at time a little bit over, but this has been an amazing discussion. It's really important. And I really appreciate all the transparency around illuminating the issues involved in this, because it's a big topic. There's a lot surrounding this, especially when it comes to the holistic aspect of it. And I appreciate the recommendations for people out there, patients and their loved ones, and Black women especially, who are expecting or going to expect, and just for living healthy lives. And Dr. Shervington, it's always about really understanding ourselves and being our best selves. So I really appreciate it. Dr. Walker, Dr. Ogunole, Dr. Shervington, and Dr. Hines, again, I really appreciate it. This has been a great discussion. Thank you so much. And for everybody out there watching, thank you so much for watching this session of Black Health Now. Have a good evening.